Welcome, everybody. This is the Accessing Long-Term Care training as part of our Public Benefits Are Key. We have amazing presenters joining us today, with which I will introduce here in just a moment. This is the Seattle King County Coalition on Homelessness. We are a nonprofit advocacy policy organization working in the intersections of homelessness, housing, human services, and really fighting for housing justice. And part of that work that we do is supporting frontline staff providers in all the work they do and making sure that they've got the information and the resources that they need to do their jobs maybe a little bit easier, a little bit more efficiently, and really help get folks the housing that they need. And so we're glad you could join us. Before we dive into our training today, and before I introduce everybody, we have Janet Varon from Northwest Health Law Advocates. Did I say that correctly?
Absolutely.
Wonderful. To give a little bit of a plug around Medicaid terminations as part of the unwinding of the public health emergency. We've talked about this before in a lot of the coalition spaces, but our partners are seeing bigger numbers and concerning numbers of folks. So we wanted to give Janet just a couple minutes to share a little bit of information and then give you all a resource of where to reach out if you're seeing stuff. So we're not going to have a whole lot of time to really do some questions, answers, or comments, but we want to make sure you have this information. So Janet, thank you for being here, and I will give the floor to you.
Thanks, Jody. Yes, what you say is true. There have been about 400,000 people terminated from Apple Health over the last few months. This is a result of the pandemic freeze on terminating people, and then now they're steamrolling through a lot, through millions of of recipients, and we're worried about these terminations, especially the ones around Apple Health classic enrollees, so people who had or are transitioning to Medicaid through DSHS because they're over 65 or experiencing disability or blindness. So maybe I would guess a number of you have a window into this population. We're really trying to find out what's going on because there shouldn't be too many terminations for that group of people. They should be transitioning to other forms of Medicaid, even if, for example, if they turn 65, they should be going on to Medicare, but also programs like the Medicare Savings Program that wrap around Medicare. So we know there's customer service backlog at DSHS's call center and CSOs. And we also recently heard that there are more SSI redeterminations happening than usual, which can also impact people's Medicaid in this group. So we are just putting out the word. We are interested in getting a sense of what's happening. We're trying to get the data from the Healthcare Authority, but they don't separate out this population from the other populations. So we don't know if they're really properly looking at whether people qualify for example, based on personal care or based on work or income. So we are looking for reports from people who are hearing from people who are being terminated. We know that for this group, it may be an issue of people not seeing the notices, not getting the notices. They can be reinstated. So we just want to make sure that the agencies are doing all they can to reinstate people if they have been terminated and to prevent any future terminations from happening for people who are still eligible. That is the pitch. Please, please, please do email me. I'll put my email in the chat again, and we can follow up outside of this call. Thank you.
Thank you, Janet. Really appreciate you taking time out of your schedule to come share this information we're going to connect with Janet and her colleagues. So we have a little bit more information to share next week at our October general membership meeting as well. So if you're looking to have maybe a little bit more information, sit with this information a little bit, we'll either grab some information from Northwest Health Law Advocates, or we may even have somebody else that can speak to this as well, and give a little time on that agenda. So Janet, we appreciate you throwing your link in the chat, or your name in the chat and email in the chat. Tim's throwing the link into that October general membership meeting so folks can join that. We're also going to have Disability Empowerment Center as a guest at our October meeting, and this is a peer-run organization that provides a lot of support, transportation, independent living, job training skills for folks that are living with a disability. And we know folks experiencing housing and homelessness, housing instability and homelessness are disproportionately affected by disability. So I think it should be a really great presentation to hear about the programs that they offer. And they really offer like a young adult, young adult, all the way up to like seniors, and very specialized programming for that. So, but we have a lot to share with you around accessing long-term care. And we have amazing presenters in the room with us to share their information. So we are really lucky to have Antonia Daramas here from Seattle Aging and Disability Services. We have Meredith Grigg from the Northwest Justice Project, Hannah Rosenberger from Solid Grounds Benefits Legal Assistance. We have Kevin Roach and Wayna Franklin from DSHS and the ALTA Home and Community Services Division. And we are going to be sharing all the things that we, and Kayla Adams from REACH is also here, who has really been instrumental in helping us think through how to present this information in a way that you as a case manager and have walking side by side with someone to navigate this information needs to know. So Kayla is going to be here throughout to sort of highlight, share stories, share her expertise of the different aspects. So like who's eligible, and how has that information been helpful for her when she didn't know it, or now that she knows it, all the way through that sort of front door of accessing services and then to the legal stuff. So we have, expertise from all aspects of how to access services, who's eligible, legal ramifications, and then actually working with someone and trying to navigate these systems with them. So we have a lot of information to share. It's why we did 2.5 hours. So on that note, I think, Antonia, are you kicking it off? And then Kayla, at the end, I know you've got your slides here, but as we talked about, like, just as you pop in with each section, things that highlight for you and that are really key for you to pull out, please just jump in. We will be watching the chat, and then we have kind of breaks for questions, but raise your hand, and Antonia, please take it away.
Yeah, hi everyone. Thank you for having me. So let me go ahead and share my screen so we can go ahead and get started. Hope you guys are having a good afternoon. And one second. Share this. Okay. I am not seeing. Hold on. Sorry, guys.
No worries. And I'm going to make you all co-hosts just in case that makes it easier.
All right. So welcome. I am going to be talking about long-term care programs. My name is Antonia, and I am with the City of Seattle Aging Disability Services. And today we're talking about the long-term care programs, what services are going to be offered in those programs that clients will be receiving once they are eligible for services. So kind of wanted to get started. When a client applies for services, the first thing that they do is receive their financial eligibility and functional eligibility. So when they determine if they're financially eligible for services, they're also receiving that determination for functional eligibility. That's my friends over at Home and Community Service provide. They're doing that initial assessment. And then our side is that ongoing annual assessment. So that's kind of where we come in, is we do an annual assessment to determine their functional eligibility for services. And you're probably wondering, well, why City of Seattle? We're offering services all the way in King County, and so how is City of Seattle involved? With the City of Seattle, so Aging Disability Services is part of that organization under the City of Seattle. We are one of the 13 AAA area on agency on aging in Washington State. At the time, we had a contract with an agreement with City of Seattle, King County, and United Way, but we are currently holding that contract to serve our AAA services. So that's probably why you're hearing City of Seattle and wondering why we provide services outside of the City of Seattle and looking at all of King County service. So just giving you a glimpse of what that looks like, you have that service for Medicare, Medicaid service, ALTSA has provided, and then you have the HCS Home and Community Service who will provide that initial assessment. And then we do that annual ongoing assessment for case management for our clients. So we have that under Aging Disability Services. And because we want to go out and make sure that we're providing services to all of our communities, we've also partnered and subcontracted with other organizations as well. So you'll often hear organizations like Lifelong, CISC, Neighborhood House, and ACRS. And a lot of these organizations are language specific, community specific, so that we're making sure that we're providing all of the services to all of the population. So it's not that they're subcontracted under us, but that doesn't mean that they're under us. It's just that that is something that we are in partnership with. So you will see all of the case managers working in different organizations, just ensuring that it's providing services for any language specific or any community for our community. When we talk about Medicaid programs, we have services under the Medicaid state plan. These are entitlement programs. Some of these services have optional services, but it is a statewide service. So you have that nursing facility. Community First Choice is going to be a majority of the program that our clients will receive. And then Medicaid personal care, only about a percentage of that will receive it because they don't, these are clients, which you'll learn later, they don't necessarily meet that nursing facility level of care. The next tier of Medicaid program is what we call the Medicaid waiver. These are optional service. When we talk about waiver, it's basically another way of saying like it's only covering a certain population or a certain percentage of the folks. So for example, COPES is a waiver program because it's only serving folks who have applied for long-term care service, age blind or disabled, or it's an optional service. New Freedom is a program because it's only offered in King County and Pierce County. So it's kind of like this demonstration and started out as that waiver program. So that's why we have that waiver. And then the last tier of programs are Medicaid service, like federal grant services like Roads to Community Living or any state funded services. This is kind of where we get a little bit more creative in how to provide services and how to provide assistance for our clients, but really being mindful about being stewards of state dollars. So we're just really being careful about how we're going to utilize this because it is federal grant and state funded. So just really attuning to how we're going to provide services. So when I talk about the services under each program, Just gonna help you out here on the top right corner, you'll see the program that I'll be sharing, and then I'll talk about the different services. So under each program, there's going to be multiple services. And then if you kind of get lost, you'll see at the top right corner, it's going to tell you what type of program a client would be in. So that first program, this is part of that entitlement program, is Medicaid program, Medicaid state program. This is really the most basic or the least services that's offered in the program because with somebody who is in a Medicaid personal care, they're not necessarily meeting that institution level of care. And when we talk about institutional level of care, there's these things called the Washington Administrative Code that is built that has definitions of somebody who doesn't fall under an institution level of care. So for somebody who is on a Medicaid personal care, there is that non-institutional category, meaning that they don't necessarily need to be in an institution and they only will receive what's called personal care. So with somebody with Medicaid personal care, they will most likely only receive that personal care, and personal care would be any physical, verbal assistance with activities of daily living or instrumental activities of daily living. And this can be a service that is provided through a home care agency or individual provider through Consumer Directed Washington. So our caregivers are just going in there and providing that personal care, and there really is only that service under that Medicaid personal care. The next program that you will find that a client can receive is called Community First Choice. This is a majority of all of our clients. About a large percentage of our clients receive Community First Choice, and these are the services that they can receive. For the purpose of this training, there's a lot of stuff to learn, a lot of the services. So I'm only going to highlight what's probably going to be helpful for you and for this audience, and what's going to help you really be creative in how to provide services and how to help out your client. But these are the services that's going to be provided under Community First Choice. Now, personal care is one of them, which I've kind of already provided that definition. And the one that is most common that we use in Community First Choice is what we call a personal emergency response system. These are electronic devices that helps a client be secure in an emergency setting. So they can have a bracelet, appendage, or any other unit to help them in case they have fallen, in case a client needs a GPS tracker, somebody with memory issues, or somebody somebody with memory issues can receive that assistance through that personal emergency response system. We have something called an add-on, so any fancy additional stuff that you can use. We cover that under what's called assistive technology. And with assistive technology, our clients every year who are in a Community First Choice gets $550 every fiscal year. So from July through June, they get $550 to spend on either an assistive technology or a skills acquisition training, or both. So with an assistive technology, these are things that's either recommended by their doctor, prescribed, but the intent of an assistive technology is to increase their independence or substitute for human assistance. So we're thinking about things like a reacher, things like a shower head, things like the medical reminders, right? If they need a medical reminder, if they need a medication reminder, is what I meant to say. They need a medication reminder. Those are types of assistive technology to help with the client. So going back to the previous slide, if there's any additional bells and whistles that they would need on top of the PERS unit, we can have that paid for under that $550 assistive technology. The other thing that can also be utilized as a 550 is what we call a skills acquisition training task. So we might have clients that need to learn basic skills acquisition, such as cooking, meal preparation, teaching them how to go shopping, housekeeping tasks, laundry, or any limited personal hygiene tasks. So imagine a client who maybe is neurodivergent and needs assistance and constant help and getting them back into a routine. That would be a time that we would spend in paying the caregiver additional $550 to teach them how to perform these things, teach them how to cook, teach them how to prepare their meals, teach them how to go and budget, right? Create a budget list, write down a shopping list for them. Any laundry, any housekeeping tasks that they may need. This is that $550 that we're paying caregivers in addition to the hours that they're already getting paid for what a client is eligible for. Now, when we talk about limited personal hygiene tasks, this is what's listed. So any assistance with bathing, dressing, applying their deodorant, washing hands and face, those are the limited personal hygiene tasks that would be included. So the caregiver is teaching a client how to perform some of these tasks, because the hope is so that the client can be independent and to safely stay in the community. So when we pay a caregiver to provide this, it's kind of training that client so that they can be independent, they can safely stay in the community. Another service that's offered under Community First Choice program is what we call a community transition service. So we have clients that are going back and forth to the hospital, and sometimes during the time that they stay in the hospital, there may be some assistance that's needed during that intermittent stay. And so we provide this community transition service. So if they're in the hospital within 30 days of discharge, we can help with a one-time setup of expenses. That can be things like helping them with security deposit, helping set up utilities and fees, getting any essential furnishings or any pest eradication services. Sometimes our clients, a situation can happen where, for example, they were in a home and the fire department had to break the door down, and then because of that, we've had to pay for that service for them, right? They're transitioning back into the community. So for them to safely stay home with a locked door, we can go ahead and make that payment for them. We can also provide one-time cleaning prior to their moving. The only thing is that when it comes to community transition, it has to be a one-time setup, so we can't provide ongoing rent or ongoing recreational items. So it's really just like a one-time setup to make sure that when our clients are discharging from a facility or a hospital, then we are ensuring that they're receiving that service. So I'm going to pause here for questions about COPES, and kind of looking at the chat, I don't see anything, but pause for questions for CSC.
And for folks that don't want to be included in the recording, you can throw your questions into the chat and I will be monitoring that. And, you know, if you're thinking about it, we can kind of keep moving on and we'll capture it later. So I don't see anything right now. Go for it.
All right. And so the next thing that we're going to talk about is the COPES program. So I don't know if you guys have seen kind of this layout before, but this is basically all of these programs that our client will receive when they are determined functionally eligible for service. So here we have our low income categorically needy clients who get Medicaid personal care and Community First Choice. Medicaid personal care is smaller because they don't get a lot of that service. And then you have the services under Community First Choice. Now you have somebody who can get COPES service. So we kind of call it COC plus COPE service because COPES can't be by itself. So we do have to have it as a waiver program. So you have that community first choice plus COPES. So either clients are on COPES because of their higher income status, or we kind of call it like a backdoor entry. So if we feel like there's services outside of community first choice that they need under COPES, we can just get that determination from the financial worker if they're eligible and if client chooses to go through this program. So these are the services that's covered under COPES. Again, it's a lot because we do provide a lot of these services, but I'm only going to highlight some of the things that might be helpful for you guys. So the next service that we have under COPES is adult day service, and it is split between adult day care and adult day health. And really the difference between the two is that one requires a skilled task. So you have adult day care, which is a supervised daytime program, and it does not require a skilled task like a nurse or a rehab therapist going in there and providing that service for the client. Adult day health is one that requires a skilled task or skilled nursing and rehab service. And these are things like nursing, physical therapy, occupational therapy. And every time a client is into the adult day health program, they have to have that skilled task with them. So a nurse is going out there, a physical therapist, they're receiving some sort of rehab service. And it's really nice because with adult day service, our clients get interaction with people. They also are receiving they're getting interaction with people, they're back into the community, and they're also receiving some of them, if you're in adult day health, are receiving that skilled task that our caregivers might not always be able to provide. So there is that reduction of personal care hours from the caregiver, but it's a benefit to the client because our clients are receiving services and our clients are getting that help from a skilled nurse and getting that rehab service. So it could be things like helping with managing their medications. It could be helping them with changing their wound. Any physical therapy or occupational therapy is part of that adult day health program. So under COPES, we also have what's called client support training. And client support training is basically any adjustment to a serious impairment, any maintenance or restoration of physical functioning, any self-management of chronic disease or skills acquisition, behavior management, and self-management. So at this time, I'm just going to show you guys the current contract that we have within Aging Disability Services. So the current client support training that we have is nutrition services. So Chicken Soup Brigade provides nutrition services for that. If our clients need help with managing their nutrition, maybe learning how to make meals properly, etc. We also have independent living skills through Validas Consulting Services. So if a client needs to learn how to become independent and learn how to navigate on their own, that is something that we offer. Our current in-home occupational and physical therapy. We also offer a mental health service under PEARLS through Sound Generations. And then if we have a client who has a chronic disease, self-management program, if they're interested, also any health coaches for hypertension, we have Kin on Community Center who can provide that client support training. So these are the current contracted services we have under client support. So Community Choice Guide is another service that is provided through COPES or provided under a COPES program, which at the time it was only offered as Washington was, it was only state funded, but then they realized the need for a Community Choice Guide. And our Community Choice Guide, the purpose of this is to establish stabilization in the community. So if a client is living in home or in a residential facility, we're making sure that they're stabilized in there. So if we need support, such as going out there and making purchases on behalf of our clients, if we're having clients needing support and looking for a residential setting, we can hire community choice guide to provide those service. So that might look like a client who has frequent institutional contacts, somebody who has high caregiver turnover, or any threat or imminent eviction or loss to current community setting. Community Choice Guide goes in there and provides that assistance, and they work with our case managers to help them stabilize back into the community. So this is basically kind of what they can get. They can look for locating for necessary resources. They can help with paperwork, transportation, and purchasing their goods and service. So for example, if you have a client who is finding an apartment, then we can have Community Choice Guide look for that apartment for them. And then they can also help with purchasing the furnitures and then working with the landlord to make those payments on behalf of the client. Additional stuff that Community Choice Guide, they do a lot of work for us actually. And so they do a lot of helping with security deposits and moving. Really, they work in partnership with us to make sure that our clients stay in the community. So the last thing I kind of just want to talk about is I'm sure really like how can you guys as case managers work with clients? We do what's called a care assessment tool. So with this care tool, this determines our client's eligibility. What has been really helpful is just providing a copy of an after visit summary, if you can provide that. Maybe have a list of their diagnoses and medications, because those are the things that we do ask. Within the care tool, it is broken down into a physical, behavioral health, ADLs and IADLs. And so you want to consider what that looks like, what type of help was provided and what type of help will be provided ongoing, and really what is the need. So as you're preparing a client for an assessment to make sure that they're determined eligible, it's asking about, how can we continue to keep the client into the community setting, and what type of help will the client need so that we can offer them with the appropriate services. I don't have, my last slide doesn't have questions. I'm at the end of the slide, so here to answer any questions that you guys have, or if you need me to go back to a slide. And also, I provided this to Tim, so if you guys need a copy of the slide, I can give that. Tim has that as well.
Great, thank you, Antonia. So as you all are sort of sitting, taking in that information or typing away as the case may be, we've got a little time here, but as I mentioned at the beginning, Kayla Adams works for REACH, and she is a public benefits specialist, and she's been a case manager for years, and was really instrumental in helping to think through elements. I mean, there's a vast amount of information that our presenters here can and could share. And Kayla was really, really instrumental in sort of like helping us think through what are the pieces that are going to be really helpful for you all. So Kayla, if I can just invite you to, share any thoughts, insights on sort of this piece of it, anything you want to, add, I think that would be really useful. So I will give you the floor should you want to take it.
All right. Yeah, thank you. So one thing I'll say is that when I was a case manager, I didn't know any of this stuff. And so this type of information, while it might seem like granular and it might seem technical in some ways, it's like, just, I don't want to say just remember it, but just know that you have it and you can go back to it if you have questions, because there are so many different programs and systems involved in getting people these specific needs met. One thing I wanted to say is Chicken Soup Brigade is fabulous. My experience with them has been that they will deliver, like, so I worked at the Morrison Hotel, for example, and they will deliver a bag of fresh fruits and vegetables and eggs and things like that. But I always would try to figure out whether a client would benefit from that or not. Like if they can't cook and they're not gonna, like, they're not interested in learning how to cook, then that doesn't really make a lot of sense for them. But their caregiver can help them with that sometimes. And so there's lots of creative ways to make those things work. And I do know that, like, you know, we started talking about right away the functional eligibility and the financial eligibility. And I just want to make sure everyone knows that we'll get into that more. So people aren't like, okay, so now I have COPES. No. There's assessments beforehand, and you know, I just want to make sure people are aware of that. And I think that's, oh, actually, adult day services. I had a question about that myself. Is that when folks go to a certain location and they actually like hang out and socialize? That's what I thought.
Yeah. So for adult day health, that is where they go. It's not uncommon for you to see an adult day health and adult daycare to be in the same place. So like Full Life has that. And so just depending on depending on the organization, you do have that socialization skills. I think at this time, because of COVID, I think things are changing now. A lot of it is still kind of telehealth, but they are starting to bring in clients. Only a certain number of clients, but they are starting to bring in clients for that community building.
Cool. Yeah, Jody, that was kind of all I took notes of throughout, like, that I wanted to make sure I got to say something about. Yeah.
Awesome. Thank you. Well, you're a wealth of information. So I want to make sure that you're throwing out some of your nuggets that you've learned over the years. Antonia, thank you so much. And as Antonia mentioned, we have all these slides. You know, we'll do our usual blog post. We'll, you know, this will all go up on our YouTube channel. And then, yeah, Tim does a really beautiful job of summarizing all of this information and providing any of the slides, and the video will be up there as well on our blog. So that's all coming. And then, you know, these are all folks that you can, you know, and agencies that we can be reaching out to too as well, because we know this is a big need and a lot of information to suss through. So if you have other questions for Antonia as we go on, I think we might have some space for that as well. So Antonia, thank you. I appreciate that. I think we're going to move on to Kevin Roach and Wayna Franklin from DSHS. So I'm going to hand the floor to you two.
All right. Excuse me. Thank you so much, Jody, and Antonia. Thank you for your presentation. We're going to bring up our presentation here real quick and see if we can get it on the screen for y'all. Start from the beginning, and then let me see if I can share this real quick.
And while Kevin's pulling up the presentation, I realize I've been mostly just verbalizing, you know, to go ahead and throw questions into the chat and comments into the chat. And that is lovely. And they are wonderful. And we will read them out loud so they get captured into the recording. But you can also just raise your hand too, if you don't mind being caught in the recording. Just a reminder that you can actually participate in this and share your expertise as well with the other experts we have on here today.
All right. Can you all see the title slide?
Yes.
All right, thank you. So my name is Kevin Roach. I am a trainer with Region 2 Home and Community Services. So Region 2 spans from Renton, basically all the way up to Bellingham, and that's our service area. I've been a trainer with our team for the last almost 6 years now, and I'll turn it over to Wayna to discuss herself and her role.
Hello, everyone. My name is Wayna Franklin. I am also a trainer with Home and Community Services. We are also social workers along with our training capacity. And Home and Community Services, our presentation is going to cover a lot of the same information that Antonia covered, probably not as in depth since she did a great job. but there will be some similar terms. We are actually the door to long-term care services, the front door to home and community services. And so you would start with us, and then cases would be transferred to Antonia's agency for continued case management. Okay, next slide. Okay, so aging and long-term care support, we're all under that umbrella. Even Antonia's agency and the agencies that they partner with are all under the ALTA umbrella. We are Home and Community Services, which is under Department of Social and Health Services. And sometimes I like to say I just work for DSHS because it's everyone knows who DSHS is. Our vision is seniors and people with disabilities, and we want to make sure that they live with good health, their independence, and they live with dignity, and they have control over their decisions that affect their lives. Our mission is to transform lives by promoting choice, independence, safety through innovative services. So we really focus on the client making choices and respecting the choices that clients make. So what do home and community services do? So HCS, you may hear of us refer to ourselves as HCS, which stands for Home and Community Services. We serve low-income Washington State residents, 18 and over, who are either blind and or disabled and need long-term care services. So they need help with their ADLs, activities of daily living, bathing, getting dressed, personal hygiene, feeding themselves, household tasks, things like that. And in that, sometimes that means that there's a placement that may be involved, or they may have skilled tasks and need more care, like nursing facility level of care. We offer nursing facility care if a individual requires skilled tasks, like nursing services. As Antonia said, we offer an array of services in the in-home setting and in the residential setting, and we'll talk a little bit more about that a few slides down. Okay, so in most cases, financial eligibility and functional eligibility determinations have to happen kind of at the same time. That doesn't always end up being the case, but most of the time they're happening at the same time, and that is a different worker than the social worker that's going to be determining the financial eligibility. So clients, when they are referred to Home and Community Services, the front door, for long-term care services, they're going to get assigned a financial worker and a social worker who determines the functional eligibility. That process can take anywhere as far as the assessment is concerned, when the social worker goes in and does the assessment, and that can happen in different settings. It can happen in the home, in the shelters, in the hospital, in the nursing facilities. And sometimes clients come into our offices and we've done assessments. We have done assessments in clients' trailers that they have. So it can happen in a lot of different settings. And those assessments that Antonia was referring to, where we're looking at functional eligibility, they can take up to an hour, as long as 4 hours. We try to get those assessments kind of done and closed out in 30 days, but sometimes that's not always the case either, because we are also looking for caregivers and placement during that time, and those processes can kind of push that timeline out past 30 days. So once an application for Medicaid long-term care is received, then a client will again have to go through a financial eligibility through a financial worker. And you've heard PBS, them referred to as PBS, which stands for Public Benefit Specialist, and a social worker. All right, I think that's all I got on that one.
All right. So we're going to talk about different ways to apply for services, and there's a number of different methods that someone can apply for Medicaid services through. The first is online. So an applicant can apply through washingtonconnection.org. That website is here on the slide. That's sort of like the main catch-all website for all applications for Apple Health or Classic Medicaid services. If a client is not appropriate for submitting an application there, they will be referred to the more appropriate place to apply for services based on their specific situation. A client can also, or an applicant can submit a form. We have DSHS form 18-005, Washington Apple Health application for long-term care / age blind disabled. That's also available on the Healthcare Authority's website. So that's www.hca.wa.gov. That application form is downloadable there if someone wants to fill out a paper copy, or they can submit that version electronically, I believe, as well. If they do download that form and fill it out by hand and want to send it in via mail, the mailing address here is here on the slide for submitting that application via postal mail. A client or an applicant can apply via the phones. They can connect with their local home and community service office and talk with a public benefit special to get the ball rolling on the financial eligibility determination process. And then they would be assigned an intake worker as well to get the ball rolling on the functional application as well. So the list of local HCS offices is linked to on this slide as well, in the fourth row here of this table. So if your client knows or they want to apply for services in like Kent, for example, they could look up the most local Kent local office that's nearby Kent and get the phone number for that office. The fax number is here in case the applicant wants to submit their application via fax. They can submit it to the 1855 number. And then they can also go in person. Any HCS office will accept an application in person. So that's always an option as well. And again, an applicant would use that office locator link in the second row there on this table to find out where, or sorry, the fourth row on this table to find out where their local HCS office is to apply in person. Okay, so we're going to talk about three different types of applicants or categories of applicants that might apply for long-term care services. We'll look at ABD, so classic Medicaid clients who are interested in TSOA or tailored support for older adults. And then finally, our Apple Health coverage for MAGI clients. And MAGI stands for Modified Adjusted Gross Income. So that's a separate subset of the client population as well. They can apply for services via the websites that are listed here on this slide. And we'll also talk about who might fall under these different client subsets on the next slides. Okay, so for our classic ABD, our age blind or disabled clients, aged is defined as 65 or older, and then the disability determination for blind or disabled is determined by the Social Security Administration. So if someone falls under one of those categories, so they're 65 or older or deemed blind or disabled by SSA, then they would apply for classic Medicaid services. They must also be a resident of Washington State at the time of application. And then like Antonia said before, they have to be assessed for needing nursing facility level of care. So NFLOC, you might hear that acronym from time to time. NFLOC just means nursing facility level of care, meaning that they could potentially receive services in a nursing facility based on their care needs. There are various gross income limits that vary by setting and program type. So we're not going to go into the fine details of those income limits, but just know that they vary depending on the setting that the client chooses to receive services in, and then also the programs they're looking to be placed onto. The resource limit for this classic group of applicants is $2,000. So that's the resource limit for someone looking to go on to classic Medicaid services. TSOA clients are those who are 55 or older, and it's a program that's a good alternative for folks who might have gross resources over $2,000. The resource limit for TSOA is up to about $53,000. So this is a good alternative to classic long-term care or classic Medicaid if your client has resources up to about $53,000. The gross income limit for an individual applying for TSOA is $2,742, and that's as of January 1st of this year. And again, this is for folks who are assessed to need nursing facility level of care or NBLOC. And the last subset that we'll talk about are folks who are interested in Apple Health coverage or MAGI, modified adjusted gross income. These are folks who were eligible through Medicaid through the Affordable Care Act and the expansion of Medicaid coverage under the ACA. So this is low or free or low cost health insurance coverage for adults, children's, family, and pregnancy programs. So this is our clients who are aged 19 to 64. There are annual household income limits that come with it as well. Clients must be U.S. citizens or meet Medicaid immigration requirements. We won't go into those details today. And they're also not entitled to Medicare. So a person who is 65 years of age or older or eligible for Medicare would not be eligible for MAGI. To apply for MAGI, a client could go online at the Health Plan Finder. They can submit the Healthcare Authority Form 18-001, and that's known as the application for healthcare coverage. And that form can be submitted via mail or fax, and those contact information is here on the slide as well. They can also make a phone call to apply over the phone at the 1855 number at the bottom of that section. And if an individual needs help or wants help applying for MAGI Medicaid, they can work with what's called a navigator or call the Health Plan Finder customer support at the number on this slide as well for assistance in applying for MAGI. Take this one.
Okay, so when we go out and do an assessment, we often give out this brochure called Medicaid and Long-Term Care Services for Adults brochure. It's really, and I don't know if you can push that link, but this brochure is basically covers everything that we're talking about here today and has a lot of the same information. It's a really large overview of the long-term care services, how to apply for Apple Health, some of the income and resource eligibility limits that Kevin mentioned, and the ones that we didn't really want to go too far in depth on are listed in there. Talks about estate recovery. A lot of people are interested in estate recovery because they have loved ones and they want to make sure that their loved ones are taken care of. It talks about the different types of programs that we have and where a client can receive services, different options. A client has resources for unpaid family caregivers. If a caregiver is a family member that's not going to be a paid caregiver, there's resources also for them as well. So this is a really good good brochure that that we give out. You can also I believe that this is also online on our out-facing ALTSA internet site. You can find a link to this brochure there as well. I would encourage everyone to just actually go to that ALTSA out-facing internet site. If you just go to Google and type ALTSA, then it's the first page that it brings you to through a Google search. And I believe we have a link to it in this PowerPoint as well.
Yeah, it should be on the previous slide, and it's a super helpful pamphlet to familiarize clients with some of the services and supports that might be available through Medicaid. So we see a lot of the same services here on the brochure that Antonia was talking about. So adult day services, assistive technology, home delivered meals, etc. All those programs are sort of fleshed out in brief descriptions in this pamphlet to help a client understand like what services might be beneficial for them, what they can expect in the application process, what are the requirements functionally and financially speaking, are they going to be a good applicant or a good candidate for applying for services. There's a lot of good information in here, and at the initial assessment, when a home and community service employee goes out to meet with the client, they should be delivering this packet or this pamphlet to the client for more information about the programs and services we offer. All right.
When we were meeting to prepare for this training, some of the questions and topics that were requested by us were to talk about some of the different settings that clients may be eligible to move into if they were found financially and functionally eligible for services. And so this slide talks about those different residential settings, which are adult family homes, adult residential care, enhanced adult residential care, and assisted living facilities are the different residential settings that a client can receive services in. And it kind of outlines the differences between those different settings. These are the only community settings that provide 24-hour care, aside from the hospital settings and the nursing facility settings that we would provide case management services to. So these are the settings that we would case manage on the home and community side. These would not go over to Antonia's agency, Aging and Disability Services, for case management. They would stay with home and community services for case management. Okay, so Kevin's going to talk about what to expect in those different settings, what kind of services a client can get. I don't know if it's too distracting to keep passing this.
No, that's all right. I can
Okay.
do over here. Yeah, excuse that. Yeah, so we just have the different residential setting options that Wayna listed. We have adult family homes, adult residential care centers, enhanced adult residential care centers, assisted living, and then enhanced services facilities. And some of these services and supports that are offered in those communities. So we won't go into all the details of this table, but it's a good reference for you and for your clients. If you're looking at specific services and supports by setting, this table is really helpful in understanding what they might be eligible for, what sort of things that they can expect in those different settings. In general, adult family homes are more appropriate for clients with higher care needs, more acute care needs, because it's a smaller client population in the home. So adult family homes are up to 6 residents. And then there's usually, there's 24-hour support staff there as well. And the ratio of client to caregiver is much lower than it is at, say, like an assisted living, for example, where there could be dozens of clients to each support staff on site. And the main things to point out here, I would say the main distinctions between these settings is that with adult family homes and EARCs and assisted living communities, there are intermittent nursing services on site, whereas with adult residential care or ARC, there is not. So that's the main distinction. And you can see some of the other differences between these facility types or community types on the table as well. We'll talk a little bit about ECS and SBS later on. You'll see that reference towards the bottom of this table as well, but we'll get into that a little bit more in a few slides. Okay, so if you have a client that's interested in looking for an adult family home or an assisted living community, they can visit this website that's linked to on this slide to search for, or sorry, that's actually a brochure about finding an assisted living or an adult family home. So it talks about sort of what they can expect when they apply for application to that community, and then some of the different services that exist at adult family homes and assisted living facilities as well. If your client wants to look for a specific adult family home in a specific community or a different specific county, for example, they could use the AFH Council's website on the bottom of this slide to conduct a search for adult family homes by county, by city, by zip code, and then look for different specialties that AFH might offer. And this is a good way to get familiar with different options local to the client.
So a question came up about different kinds of supports that we can offer a client that might have behavioral issues and or substance abuse issues. So in the residential settings of adult family home settings, the caregiver, you can just leave it over there. The caregiver is eligible for a meaningful day contract, which gives them more money to provide behavioral interventions, and they will have someone work with them to set up those type of interventions in that home. So they create a plan and activities that are tailored to that client's behaviors to help manage those behaviors and those barriers. And again, they will be assigned or can ask for some help to come up with those type of plans. But that's something extra that an adult family home provider can sign up for. And on that search that Kevin was talking to you about in that link, when you do that search, it will let you know if that particular home has that kind of contract. So if you are a case manager and you're trying to help your client look for a home, then you can certainly put that in the search feature. The other, some of the other services that might help with behaviors in the residential settings is called Residential Support Waiver, RSW. It provides specialized services to clients with behavioral needs as well. Again, you will see the home that has those specific contracts. Not everyone has these contracts. They have to have signed up for them and have special training. And they do get extra funding to support clients with these type of needs. And in RSW, under RSW, there's a program called Expanded Community Services. We refer to it as ECS. And so they receive contracted behavior support, and they will be assigned a behavioral specialist to help them. The same with a home that has a SBS contract, which stands for Specialized Behavior Support. A client that is eligible for SBS would need to, they would have to have a need for one-to-one staffing. So this would be clients that have like severe behaviors that might be up all night and have some kind of wandering or, some really egregious behaviors that require more one-to-one caregiving. And we would do, home and community services, social workers would do the assessments to determine the eligibility on our side, but we would have to work with the home and see if they have the contract to take those clients. So all of our clients, when they become eligible, they have on their medical coupon, it allows them to receive treatment and evaluation for substance and alcohol abuse and any kind of emotional support, crisis and intervention. So it comes along with their medical, and I believe isn't it all Apple? Mm-hmm. Anybody with a medical coupon can access Washington State Recovery Helpline for treatment. So all Medicaid eligible clients under the Affordable Care Act. And so a lot of times when I was doing case management, I would have the adult family home, if they were interested in a client and we try to tell them up front that the client has substance abuse issues and or some type of behavioral or mental health, they would draw up a contract and have the client sign it to say that they agree to receive treatment before admitting into their adult family home. They also sometimes put in the contract, this is outside of home and community services, this is totally up to the adult family home and the residential settings, for that client to also be connected to a protective payee, which is an outside entity that will manage their funds, because those adult family home providers and residential providers want to make sure that they're getting paid. And sometimes that can be also set up if they are receiving Social Security through Social Security.
Okay, another question that we got when we were preparing for this training is, what sort of discretion does a facility have, such as like an adult family home or an assisted living community, for example? What sort of discretion do they have to transfer or discharge a client? And so we cited a WAC here, so Washington Administrative Code 388-76-10616, that talks specifically about a facility's discretion and the resident's rights. So this talks more specifically about the transfer and discharge notice and the obligation that a provider has to provide notice to a client if they intend to transfer or discharge the client for various reasons. Typically, that could be health and safety of the client themselves or the provider or the caregivers on site or other clients. I would say that's probably the most often reason that we see a facility or a community looking to transfer discharge a client. If a client goes on medical leave, for example, they have a medical event and then they're in a hospital for an extended period of time, and that facility feels that they can no longer physically care for the client because their care needs have become so acute, that could be another reason that they're looking to discharge or transfer a client to another home. When a client does go on a bed hold, so they go on medical leave, the facility that they discharge from to the hospital or the skilled nursing facility is obligated to hold their bed for 20 days. And then after 20 days, they have the right to offer that bed up to someone else, because we will only reimburse the facility for 20 days to hold the client's bed. After that, they have the right to ask someone else to offer that bed up to someone else that's interested in moving into their home. So this is information about the types of information that the facility or the community must provide the resident if they intend to transfer or discharge them. That's all laid out here. And so that's something that you all can read on your own time. If you have any questions about this, you can reach out to Wayne or I, and we'll be happy to staff it with you. Just know that if there is ever a contention between a provider and a client, and the client is worried about losing their placement or their spot where they're residing, that's something that we could refer to RCS, which stands for Residential Care Services, and they will actually go in and investigate the nature of the disagreement to see if the provider has the actual right to ask the client to leave if there's some sort of issue that they're concerned about. So we have an outside entity that actually investigates potential issues around discharging a client and whether or not they're valid from the provider's perspective. All right, the other question that we had about navigating the long-term care application process and sort of ongoing support for clients, and who is responsible or who is available to support with that at every step of the way. We have just some basic information about what that might look like. So when a client is applying for services, they will be assigned an intake worker and a financial worker, and those individuals will work with the client on determining initial eligibility. So for the financial worker or the public benefit specialist, as Wayna alluded to, will help determine financial eligibility for services. And then the intake worker will assign the case to a case manager with a department or a nursing care consultant with a department. And then that individual goes out and conducts the care assessment that Antonia was talking about to determine functional eligibility. So these two pieces of eligibility are usually happening simultaneously to see if the client is functionally eligible for services and financially eligible for services. But prior to that, if the client needs assistance with applying itself, the person who is most likely going to help them if they need help applying is someone from a local social service agency or a hospital, for example. It could be a hospital social worker who's filling out the application for long-term care services. I worked at Plymouth Housing Group before I worked with HCS, and I filled out a couple of applications with clients for long-term care services and supports through HCS. And so it's not uncommon that folks with various nonprofits or local nonprofits will assist the client in applying for services. And that's the initial contact that they have with the department. After a client has applied for services, if they are found to be functionally and financially eligible for services, the case manager or the nursing care consultant can assist the client with identifying the programs and services that are available to them. So part of our role as assessors and part of what we are required to do is to inform the client of all the programs and services that they're eligible for, and then leave the choice of where the client receives their services with the client. That's their decision to make, and our charge is to support them as best we can in that process. If the client would like assistance with identifying additional options that maybe the case manager doesn't have knowledge of, or there are outside resources that are external to HCS, like Antonia talked about before, this is where a community choice guide can be a huge benefit. CCGs can assist the client with accessing outside community resources, identifying viable community living options, and then establishing networks with relevant participant providers. So this could be behavioral health providers, this could be physical health providers, things like that, to help the client better integrate and connect with their local community and get the support that they may be looking for. So there are there are individuals to help facilitate and assist at every step of the way. It just sort of depends on where in the process the client is with applying to services. All right, and that is all we had. So wanted to open it up for any questions, comments, concerns while we're here.
Thank you. I am not seeing anything in the chat at the moment, but again, just raise your hand if you got a question or you want to type it in. But I'm going to do the same thing. I'm going to invite Kayla to jump in here and share some of her thoughts of what information she has really utilized over the years or wish she had known way back when. So Kayla, I would love to invite you to step in here as people are throwing stuff into the chat and raising hands.
Okay, cool. Yeah, one thing that this is sort of in chronological order from their presentation, some notes I wrote. If you're going to be the primary person helping your client apply for these services, make sure you answer your phone or call people back, because obviously, like, you will only get so much time to really go through this process. And so when, like, for example, like, I would put my phone number down as the referent, I believe, and the social worker would call me or their case manager would call me, and we'd figure out a time to coordinate with the client when we're going to meet. And I've done that a lot. And it's, especially with the clients I used to work with, they were acutely mentally ill. And a lot of them have substance use disorder issues, and just the lack of disorder or the lack of organization often requires someone like us, like a case manager, to be side by side with them through this and to do some of the back end coordinating. So just, I mean, it sounds basic, but make sure you answer your phone when they call, and call them back as soon as you can. So, because you don't want to miss the opportunity, I guess. There was some talk about resources and money, and I just want to point out that it is a big reason why some folks don't want to go into these facilities, is because a pretty good chunk of their money that they receive, like SSI, SSDI, is going to be taken out of their paycheck to be paying for some of these services. And I don't know the ins and outs of it specifically, but I do know, and clients do know, that this is the case. And so I've had a lot of folks go through the whole process, and then they're like, nah, they're going to take all my money. And so that's not a true statement. There is some money left, but just being upfront with folks, I think, is always a good idea, especially since this is such a, in my opinion, a big deal. They're being pretty vulnerable in handing over their care to another facility or person even. I love the brochure. I know that's nerdy, but I would always get it at the end of the care assessment or the end of the social worker evaluation. And that's great, but because it is available to anyone online, I know for a fact, I've been there. I liked to have it with me just so I can, like, either for my own education or to show the client, like, these are the different types of services that are available. I'm not saying you are eligible for them, but, like, do any of these sound interesting to you? Like, just to do a sort of assessment of what they actually want. And again, being very, very clear that it doesn't mean they're going to be found eligible. That table is a great reference. Like Kevin said, it's a great reference because it does denote levels of service and types of services at each site, like at the different kinds of sites. And so it's just another way of looking at what's available for the client to kind of see what interests them. Because I do want to say, and I know we'll get into it at some point, that it is entirely up to them whether they accept these services. So they could be given all the hours for chore workers. They could be given all, they could be given the best placement. I don't even know what that means. And they could say no. And that's just a fact. And I have a couple of slides at the very end about kind of how I've dealt with that in the past as a case manager. I promise I'm hurrying. Let's see.
You do not, Kayla, you don't have to. We're doing great on time. So
okay, good.
yeah.
I know there's so much material. Okay, so then Wayno mentioned these contracts with the SBS and the ECS, and the fact that they are, or no, I'm sorry. What I meant to say was the contracts that the facilities make on their own that don't have to do with HCS, and that they are discretionary. And that's a huge thing I learned, is that so much, once you get to the point of someone being eligible for placement in a facility, that facility has a ton of discretion, a ton. And like there was that slide that I think Kevin went down the list, but and I'm not trying to be, negative over here, but I've had clients that were kicked out for really inappropriate reasons. And I will say this, that Meredith and Hannah will get into what to do then. Because I didn't know what to do at the time. I just was like, okay, I guess my client's homeless now. It was horrible. And so I really, really recommend going into detail with the client on what they're getting themselves into, so to speak. It sounds kind of daunting or scary almost, but it's more just like the more they know, the better they can make a, well-informed decision. And so as Wayno was mentioning that, the facility might say you have to get treatment first, or you have to have a payee first. I want to highlight for folks who are familiar with and hold housing first as a value that that's not housing first, but that is up to the facility. It's not DSHS isn't saying that's, like we love that. It's the facility gets to decide who they let in the door. And then, oh yeah, I think I already said this, but who helps people apply? Oftentimes you will, as the case manager. I've helped people apply many, many times. I like to recommend the person that they're the professional in their life that knows them best, because they'll be the ones to maybe have a better idea of what they truly need and don't need. And I will get into it in my slides, but there are times when the client and you disagree on what they need, or what they think they need, what you think they need, and then of course what they want. And so there's a lot of nuance there, and whoever knows them best and can kind of be there throughout, I think is the best person to help them side by side.
Very good.
Absolutely. Yeah, I just want to touch on one piece that you mentioned, Caleb, or sorry, Kayla. Kayla. I was thinking of my friend Kayla when I said your name. I apologize. But yeah, personal needs allowance. So clients have to contribute towards their cost of care, like you mentioned, and that's something that may catch some people off guard. So our folks who go into a residential community, like an assisted living or adult family home, they get what's called a personal needs allowance. And that personal needs allowance for residential setting is $100 a month. So if they have income, they're guaranteed to keep at least $100 of their income. And then depending on their cost of care, they could pay a vast portion of the remainder of their income towards their cost of care, or potentially all of it. Depends where their income is at, and then also what their cost of care is as determined by the care assessment. The personal needs allowance for in-home clients or services is much higher. It's $2,742. So your client's cost of care would have to be greater than that number for them to have to pay towards their cost of care. And I'll put those two numbers in the chat as well, just because I think that's a great point, and that's something that we should be discussing at every initial assessment for the client to chat with their public benefits specialist if they have more specific questions about what their cost of care will look like and what they should expect to pay out of pocket.
And then also, since you gave me those numbers, thank you so much. I knew it was low. And it's just a huge barrier for folks, especially if they are, and I mean, substance use and cigarettes are also big barriers for facilities, and placement on their own. But if you're spending a bunch of money on cigarettes and or substances that you use, you have $100 now. And like, you know, and if you have a payee, they might be really, you know, restricting that even itself. So I also in my slide have something about the substance use and cigarette stuff, but just wanted to throw it out there so people can think about it, I suppose.
Yeah, thank you all. I'm not seeing any questions coming in through the chat, but you know, even if you just have a comment or you know an experience that you had that feels like, it's not really matching up with the information that's being shared. These are the folks to ask that question to maybe unpack, you know, a little bit of what happened there. So while you're kind of thinking about it, I'm gonna throw a link at this point for a post-training survey. We here at the coalition really value your feedback on our trainings. And this is a new training that we've offered. We hadn't partnered with you know, the Home and Community Services folks this way before, nor Seattle Aging Disability Services. We've done stuff with REACH and Solid Ground and Northwest Justice Project before, but we want to make sure that this is getting you the information that you need. If you need us to go higher level, like we were too in the weeds, or you need to be more in the weeds, like this is information that we want to refine and really make useful for you, because we know folks that are experiencing housing instability and currently experiencing homelessness or living outside, they're getting older, they're trending older. And we also know that that experience of homelessness really takes I mean, certainly an emotional and a mental, but also a really big physical toll on folks. And folks that have a disability in any number of ways is really high. And so these services are really needed, right? And making sure you have the information of how to access that. And then these nuances that everybody's touching on, and I think Kayla is really opening up for us, is really huge. So please, if you have a moment, fill out that survey. Tim and I really do look at it. We really do make decisions based on it. You know, I think this based on the fact that we had over 100 people register for this. This is needed, and we might want to talk with our beautiful partners here about what it might look like to do another one in 2024 at some point. So just that's my shameless plug to give us some feedback so we can show up for you all better. And then I'm seeing a question in the chat. I had a veteran where their case manager dropped the ball. Who can we call on for support? Great question.
Is it an in-home case manager, or guess more information about the question?
Hi, this is William, Bellwether Housing. There was a veteran that was going through some substance issues as well, right along with housing violation concerns. And their case manager completely dropped the ball altogether when it came to meeting and having a discussion about the lease violations and finding him alternate housing. And it basically came down to like the last week of us going over at least 3 months of just frivolous discussions about what can we do to move forward. And he literally told me, at this point, there's nothing I can do. And a week later, the client was homeless. And he came back to where he was living before, where I facilitate. And I basically had to help him out and get him in a shelter. And I felt like I was between a rock and a hard place, because I knew something could have been done before we came to this point. But what more could I do if he has a case manager and his case manager is held responsible for all his living arrangements and everything else in between?
Are you meaning the case manager through HCS? Or
No, it'd be a case manager through VA.
oh. I mean, no one likes a snitch, but I would have gone to their supervisor.
I did.
Yeah.
I did reach out to the supervisor, and the supervisor basically was throwing it back on the case manager to handle the case. I included them in all conversations and also a string of emails in regards to how urgent this was. And the response more or less was like, well, the case manager is going to take care of it. And then finally, the case manager said, there's nothing I can do.
If I've been in similar positions, honestly, and things that I've done, I've personally have just like taken completely over the situation, which isn't on, not everyone has that ability or bandwidth. If you can't tell, I was probably a little bit of a control freak. But I would also like maybe, I don't know, I've roped in APS, even though they don't really do anything. No offense, actually, APS is great, but APS, I think just like having them look into something freaks people out, and might, you know, get them to do it. And then also, I wonder if Meredith and Hannah have any recommendations. I know it's maybe not legal yet at the point that you were discussing, where the case manager is still there and like isn't really helping, but there is probably a point somewhere where legal could get involved, but I'm not sure about that exactly. Supervisor, yeah. Just go to the executive director.
Snitches. No, I mean, I agree with what Kayla says. And I would also just say, William, I know less about the veterans program because we at Northwest Justice Project, we have attorneys who deal specifically with veterans benefits. So if you want to, my contact information is there. If you want to send me an email, I can ask our group that works with veterans if they have other solutions for when they've got, someone with housing issues who's not getting the help they need from their VA case manager. And, also happy to share with the rest of the group. I could send it to Jody and Tim as well.
Thank you. I really do appreciate it. The upside is we actually went through a situation where he was removed from service because he wasn't, corresponding and meeting back up with his case manager and meeting the groups he was supposed to be meeting with. So as I conducted my due diligence, and I have the faith of, I don't want to look back and say, did I do right by that person? Because if I have to look back, then I didn't do right by them, right? So I did everything I could. Actually, me and the team here at Bellwether did everything we could to get him housed for that night. We ended up getting him case management services, and he is now at the William Booth Center. But to say that at one point in time he was housed, he had a housing voucher, to be a week later, unfortunately, homeless. No voucher, no nothing, no mailing address. So it felt as if I dropped the ball somewhere. That was my first rodeo, and I want to look at it as a rodeo. And I don't want to ever go back to that situation again. So I would want to just make sure that I have all my ducks in a row from now on, and to make sure that, help me help you, even if it's the case manager seeking the help the most. So I really do appreciate it, and thank you. Thank you.
Thank you. And April from Solid Ground threw in the chat for veterans, specifically the King County Veterans Program might be able to assist with a VA benefit issue. And that is a great call out, April. Thank you for that. Tim then threw the King County Veterans Program homepage into the link. And I will just say they are going to be joining the coalition for our November general membership meeting. And why one of the reasons they are an amazing benefit is they have a really wide definition and broad definition of who qualifies as a vet, which I'm not going to speak to details because that is not my, I will get it wrong, no doubt, but it's much wider than the VA as a federal entity or a state entity defines it. And they also really try to help family members. So just in relation to that, I'm wondering, because this is a really specific and really quite, tragic example, William. So I'm really sorry that happened for that particular client and you and your staff that were really helping. I'm curious, Antonia, Kevin, Wayna, is, are there any processes where if someone finds themselves in a similar type situation where they can, put in a request to expedite a process under an emergent situation, or is that just kind of not a thing that your agencies in sort of the big systems that they are able to do? I'm just wondering, to follow up on that example.
We certainly do have, we're not, we do say that we're not kind of an emergency service type agency, but we do have some things that we can put in place to expedite processes. We have what's called a fast track. If the client is functionally eligible, but maybe their financial is kind of holding them up and they look like they might be financially eligible, then we can have them sign a fast track, which will allow them 90 days to kind of get their financial situated, and we can go ahead and put them on services for that 90 days. So that's one thing that they can do. If there's ever any issues that William described in the residential setting, Kevin had mentioned that we can reach out to RCS and APS, and there's an ombudsman in that WAC that speaks to that. And also on that Adult Family Home Council page are those kind of resources. And sometimes we have dual clients where they are VA clients and our clients, and we try to work together to prevent situations like that. But I have certainly in all my years of almost 27 years of working here have heard of situations that William described, unfortunately happening or on the verge of happening, and we try to come together to work to see how we can prevent something like that.
Thank you for that.
Oh.
Before you jump in, Antonia, I threw an APS in the chat, Adult Protective Services. What was the other one? RCP. I missed it. And what was that?
RCS, which is Residential Care Services. And that is also on our ALSA homepage site. You should be able to find a link to Residential Care Services as well with that link.
Great, thank you. Antonia, please take it away.
Oh yeah, I was just gonna say, even for us for in-home services, we do have supports. We have CCGs that we can get involved, provide temporary housing for our clients. And it's not on, we have cases where we also kind of have VA, they also get VA case management services. I mean, I think this is kind of where it's important to really know who the circle is in the client's situation, because you kind of end up in that, like, you guys know that meme with like that Spider-Man and they're all pointing. It becomes that, right? And so it's really important to just like always have that constant communication with the different circles that the client has, because then it's not uncommon for us to say, well, we can't help, they have to help, so and so and so. But for us, we do have those resources, and sometimes it just can be limited, because if we've already provided it one time and that happened again 3 months later, that's kind of where it gets really tricky.
Really, really appreciate all that insight. And Kayla, I feel like it's in alignment with what you've talked about before in terms of like just the amount of information and coordination that a case manager plays or can play in this. And it's just y'all hold so much on your plates, and so hopefully this is helping to maybe make a little room at the edges for you. And we're getting a thank you greatly from William in the chat. So, and Meredith threw in the link for the Washington Long-Term Care Ombuds Program. Thank you for that. We are, and we're still doing really great on time, but I just want to we're about to move into our legal perspective. So before we just shift into that, are there any sort of follow-up comments or questions just really about, sort of that eligibility, whether it's the financial or the functional eligibility, sort of the different programs that folks have access to? Kayla, you look like you're itching to come off mute. Am I right?
Yeah, I mean, I was just gonna say, as far as the functional eligibility piece, like you can only prepare a client so much for that assessment, but in my slides in the section after legal, I have a couple little tools that either I made up or I'm aware of that folks can use to just help the client prepare for the types of questions they're going to be asked. And I'll get into that more in my section. And then I also just wanted to say what Antonio was speaking about, and what we've all been speaking about at this point, is care coordination is key. So we should do a care coordination is key training series. Except for that, actually the King County has a care coordination training, which I will link to later because there's other trainings in there that might be relevant to the thing I'm about to talk about during my section. Okay, I think that's it until my section. Yeah.
You jump in whenever you want. Kevin, Wayna, thank you so much. We are going to turn it over to Hannah Rosenberger and Meredith Grigg. Hannah's from Solid Grounds Benefits Legal Assistance Program, and Meredith is from Northwest Justice Project. So please take it away.
Great. Thank you, Jody. I'm going to go ahead and share our PowerPoint presentation. All right. Yes. Yeah. And as Jody mentioned, this is the legal stuff. So Hannah, would you like to I have our contact information. Jody introduced us. We can quickly say hi, who we are, and then move along.
Sure. Yeah, I'll give a brief intro. So I'm Hannah Rosenberger. I'm the program manager for the Benefits Legal Assistance Program at Solid Ground. Solid Ground is a large social service agency located in Seattle, and Benefits Legal Assistance, we work with low-income individuals and families in King County and help them when they are running into issues with state public benefits. So today we'll be talking about long-term care, but we also help families who are having issues with their TANF, individuals who maybe are receiving age, blind, and disabled cash benefits, Medicaid, food assistance, and the Washington Working Families Child Care Subsidy as well. So we support clients who are trying to navigate those benefits. Happy to be here with you all.
Hey, great. Thanks, Hannah. And I'm Meredith Grigg. I'm an attorney with the Northwest Justice Project. And the Northwest Justice Project is a statewide legal aid provider. So we do a whole variety of things, from family law to evictions to just a bunch of stuff. But I'm at the office in Seattle, and I work primarily on public benefits, and specifically with seniors because we have a contract with Aging Disability Services to provide services to folks who are 60 and older, regardless of income and assets. So my focus is specifically on public benefits, but we also help seniors with housing issues, family issues, and kind of civil legal services. And just to give you an idea of where Hannah and I are headed, we're going to bounce back and forth, but this is our outline. We'll spend just a minute talking about long-term care benefits. Our co-presenters have done a much better job of talking about these different benefits programs. What Hannah and I often see, unfortunately, is when things go awry, and we'll talk a little bit. We'll mention some of the problems that Hannah and I frequently see. Obviously, there are other issues, and if you have questions, feel free to throw them out. But we'll touch on the big ones we tend to see. And then we'll talk about the solutions that we commonly pull from our toolkit to try to help folks solve these problems. Some of them are legal, some of them are just more problem solving. And then you all probably have tons of solutions that you've turned to try to resolve problems that your people are having with benefits. Hannah is going to talk a bit about equal access plans, what those are, and how clients can access them. And then we'll talk about some resources where you all can go to find quick information, hopefully, especially like the numbers, which we're all like searching for at those crucial times. So that's sort of where we're headed. We'll start again with what long-term care benefits we're talking about. And like I said, I'll be quick because our wonderful co-presenters have already covered a bunch of this, but the different Medicaid benefits as we've talked about. And today we're focused on long-term care Medicaid. I will mention, as Kevin and Wayne and Antonia have mentioned, and Kayla, there are asset and income limits, which is often where we see some problems, and we'll talk about some solutions. And then the common long-term care settings, and again, folks have spoken about this. These are the ones Hannah and I typically are dealing with. There are some others, but folks who need care at home, folks in adult family homes, assisted living, skilled nursing facilities. Our other presenters mentioned enhanced services facilities, veterans homes. There are a variety of places where folks can go to get the kind of care they need. Again, the least restrictive setting is what we're all going for, to give people as much autonomy and dignity as they need, but also balance that with getting the amount of care that they need to live safely. And that's just like one thing I'll mention about assisted living facilities, and the thing that comes up probably, Hannah, for you and for me is there's this often when somebody calls and says, I'm having a problem with my assisted living, I have to dig a little deeper to make sure they're in the part of the assisted living facility that's the assisted living facility. So just a note that sometimes we'll have folks come to us who are living in the independent section, and different rules and laws apply to those folks and the folks who are actually receiving assisted living facility services in an assisted living facility. So just to be very specific, that's what we're talking about. And then we're going to talk a bit about what problems folks are encountering in long-term care. Hannah, I'm just going to keep kind of advancing through, but I know that you're doing some of these and I'm doing some of these, so we'll go. I think the first one's yours.
Yes. Yeah. So what I wanted to touch on today is, when something goes wrong, hopefully things go smoothly, but just, sometimes a client will hit an obstacle or barrier. And sometimes what I've seen is that clients, maybe they get a notice they've been denied, or and they just stop right there, or maybe they wait a couple months to apply. But there are actually solutions and things that the clients can do, or maybe you as a case manager can note so that they don't have to just keep trying again. Folks can get denied. I think Antonia mentioned this, did a really good job explaining. There's that financial piece and then the functional eligibility. So someone might be denied because they're not financially eligible or not functionally eligible, and that it's determined that they're not needing that level of care where they need that assistance to be able to continue to live independently. And I just wanted to share a brief example of a case that I had recently to kind of demonstrate what might this look like for someone. I had a client who was applying for long-term care, was denied because was found not to be financially eligible because there is this asset verification. So when the department did a check, this bank account showed up with thousands of dollars in it. Maybe it was like $5,000 or something. So that put him over the limit, but my client had no idea what this bank account was. And so it turned out it was a shared account from when he was previously married, years before. His name just hadn't ever been removed. So we were able to help resolve that issue, work with the spouse, the bank. We were, prove that that wasn't his money and he can move on to the next step. So just these, and we didn't have to file a hearing request. We just got some additional information, gave it to the DSHS folks, we were able to resolve the issue. So just wanted to flag that. We'll talk about what it means to request a hearing, but there's also some other solutions that you can ask the department to review or reconsider, or you give additional information. I think that's what I wanted to say about that piece. This letter here, this is a sample. Oh, actually, if you go back, yes. So this is a sample of a denial letter. And I just wanted to note that and this isn't just for long-term care. I mentioned I do a lot of other types of benefits. When anyone is getting a notice from DSHS or the Healthcare Authority, it's required to have certain information, or else it's not good notice and the department has to go back and fix it. So it should have the reason for the denial, specific rule citations, and include information about your right to a hearing, which just this example, this does. And then, okay, now I think we can move to the next slide. So we talked about what might happen when someone gets denied, what that might look like. There's another situation that we see often as well. When somebody, they go through the process, they get their assessment, they are awarded, let's say they're getting personal care hours, but maybe it's not sufficient enough. So a client is maybe awarded 30 hours of caregiver, 30 personal caregiver hours a month, but they feel like they need 60 to be able to live independently. So that might be an issue that comes up when somebody's going through this long-term care process. This page is actually an example of a planned action notice. It's just the first page. This is the letter that DSHS will send after an assessment, and it tells the client exactly how many hours they were awarded, if there were any changes, and it gives more details about the assessment and why the hours were calculated the way that they were. So this is a really helpful piece of paper to review, or maybe your client can't find a copy of their planned action notice. If you can get a copy, it's going to be really helpful so you know exactly why they were approved for what level of service. And it also includes information about how to request a hearing if the client doesn't agree with the decision that they received at this step. Okay, I think the next slide, I'm passing it back to Meredith.
Yeah. And I'll just say to you, Hannah, I'm like looking at this. This is from a reassessment. So I think Wayna and Kevin and Antonia did a good job of sort of differentiating between sort of the initial assessment and then a reassessment. So for this client, it was a reassessment where her hours were reduced. And she really felt like she still needed the same level of care in her home. And I also thinking we're going to need a new example too, because it's still got like the COVID language. It's like, because the notice is from 2020, it was like, don't worry, it won't change. But like, anyway, someday this will happen, which is what Janet talked about. So full circle. The other issue we're seeing a lot of, and Kevin and Wayna talked about this, is involuntary discharge or transfer from residential care that the resident doesn't want. Kevin mentioned the different reasons why someone might be discharged from their adult family home, their assisted living, or their nursing home, or some of these other facilities. We're seeing a lot of it right now. And I think one of the hard things about this is the laws for discharge and transfer are frankly just not very clear. There's not only the rules for licensing these facilities that set out very clearly sort of what their duties are when they want to discharge or transfer somebody, or they need to. And then on top of that is the Long-Term Care Residents' Rights Act, which piles on some other requirements that maybe aren't so clear. I'm usually representing the resident in these cases, but I have just so much empathy for the facility owner trying to look at these laws and figure it out. So sort of stay tuned. There's a lot of work on all sides to clarify the rules and laws about what happens when somebody needs to be transferred or discharged from the facility for whatever reason, or what might it look like for the person to stay and get the support they need? Are there problems that we can, resolve? Is it about money? Or like Hannah said, are there some sort of simple solutions that it's just about connecting the dots? But I will say this is a really difficult area of the law at the moment, is fine, it always has been, but like at the moment, because there's just a lot of confusion, and I'm seeing, at least from my end, a lot of times where the facilities are doing their best, but they're getting it wrong in terms of the notice and their duties to the resident prior to discharge or transfer. And we're trying to come up with good solutions to keep people safe. But there are lots of different rules and laws for very good reason to protect people who are living in facilities, who need long-term care, who are inherently vulnerable. So you can't just evict them like you would anybody. There are a lot of rules and protections for those folks. Another issue, I wouldn't call it a problem necessarily, folks. As we've mentioned before, you know, there are asset limits, and we talk about that financial eligibility. There are asset limits. So sometimes we have folks come to us who have just received a settlement, perhaps in a personal injury lawsuit, or they've gotten an inheritance from, you know, their long lost uncle. So lovely, but it could screw up their benefits if it's going to put them over that $2,000 asset limit. So we'll talk a little bit about some different solutions for that, but just flagging that as an issue, as well as gifts. And I'm not talking now about gifts to the beneficiary, the person who receives the benefits, but situations where a person who has either applied for benefits or is already on long-term care benefits, and they make a gift or they give away some of their property that would then make them ineligible. So the common is somebody who's just applying, and when the financial eligibility review is happening, they see that this person transferred their home to their kids. You know, all well-meaning, they really want the kids to get the home when they die, but according to the rules, that's not an acceptable transfer, and it can make them ineligible for benefits. And there are solutions to that as well. Those are just I just want to flag the asset limits. And then Wayna mentioned estate recovery is an issue for folks. Again, just to like flag what Kayla's talking about, you know, we talk about these benefits and we're like, hooray, congratulations, you just, you know, got long-term care benefits, live in an adult family home. By the way, they're going to take all your money except for $100, and they'll take your house after you die. So way to go. So it's all, we do this counseling and we talk about it, and it is a great benefit, and it is often in their best interest, but it can take some gentle explanation about sort of what the restrictions are, what some other things like estate recovery might mean or might not mean, and we'll talk about that. But there are a lot of reasons why for us, we're thinking, well, wonderful, this person just qualified for this benefit, and the person might say, nah, thanks, I'm good. That was a really good point. So now Hannah and I'm sorry, Hannah, did you want to speak on any of the problems we mentioned?
No, I was just going to say, so Meredith and our other colleagues at Northwest Justice in partnership with the coalition, did a more in-depth training on the involuntary discharge for long-term care. I think that was a couple months ago. It's on the coalition's blog. So I attended just as a participant. It was really helpful. So if you have more questions about that, I really recommend going back and watching that training. But that's the only thing I wanted to add in that section.
Thanks, Anna. All right, so we'll talk a little bit about some solutions that Hannah and I have been able to use. You might have some others. We'll start with the problem of somebody who's been denied or not offered enough benefits. This is you, Hannah.
Yes, so I'm going to dive in. So one thing we mentioned, someone might either be denied, that they're not eligible for services, or maybe they're approved, but they don't feel like the hours are sufficient. So there's this option. It's called an exception to the rule. So generally, somebody has to meet certain requirements to be able to get benefits. However, if their situation is so unique that maybe they can still get these benefits even if they don't meet every single requirement, and that is that's usually called an exception to the rule. And I have these notes, so I want to actually make sure I say everything correctly. It's not just for long-term care. I know we're talking about long-term care, but oh, sorry, I thought I was echoing, but oh, that's somebody else's echo, not me. Not just for long-term care. If somebody is receiving coverage at the healthcare authority or other state benefits, this is also an option, but I'm just going to talk about the long-term care. So this is a good tool if your client has a really unique situation that means they need an extra level of care or a different type of care than maybe somebody in a similar situation. There's no deadline to request an ETR. There are deadlines for hearings and to actually appeal the results of the assessment. So we'll get to that shortly. But I would say the sooner you can ask for it, the better, because it could take several weeks to get it reviewed. You might need to be helping your client get additional documents to include in this ETR. And I do want to flag that you can ask for this exception to the rule, or your client can ask and appeal the decision as well. You can do both at the same time. And if this exception gets approved, and let's say your client gets on benefits or their hours are increased, they can always cancel the hearing if it's not necessary, but you don't have to choose. You can do both. So some questions, like if you're thinking, well, is this right for my client? Is an ETR? If their situation is, different than others. So I just wanted to give an example of a client I worked with last year. They were approved for a certain amount of hours, felt that they needed more. And the reason they needed more is because they really needed someone checking in on them so that they were staying alive. They had a very serious mental health issue that they were dealing with. Also, physically, maybe they didn't need as many hours, but they really needed that almost daily check-in. So we were able to get an ETR because that situation was very unique. If your client has an impairment or a limitation that's making them hard to even, to participate in the normal eligibility process, an ETR might be a good solution for them. To request an ETR, you can ask your long-term care case manager, let them know the situation. Oftentimes, I've seen that the long-term care case manager will actually say, there's this option, do you want us to try it? And they'll submit that, or the client, or with the help of their case manager, they can actually submit. This is a sample letter on the screen. And actually, we're going to get to the resources later, but there is a template about how to ask for an ETR and even a sample letter that you can just copy and paste on Washington Law Help. So I'll give you that link. But so you don't have to come up with how you actually ask for an ETR. There's some sample templates out there. Generally, you're going to need to provide additional evidence, whether it's medical evidence or maybe a letter from the caregiver or friends and family, just explaining why the situation is different and why they need this exception to the rule. So that's the ETRs.
Great, thank you, Hannah. And I was going to say, I totally agree. There have been times where, well, one, I think your point about the fact that you can ask for the ETR, the exception to rule at any time. So it might be that the person receiving benefits has requested an administrative hearing, like Hannah will talk about in just a moment, and an exception to rule. And, in my opinion, the best case scenario is the exception to rule is granted, or there's some resolution before we even have to go to hearing, so that we can cancel that hearing, get the person the care they need, if it's appropriate. And then, for this person, I wrote the letter just because I was already representing them in their hearing, and because they had long COVID and there just wasn't sort of the care tool didn't quite accommodate for what she was experiencing. So we not only did the letter, but her caregivers both wrote up statements about how her condition was and how it was different since she'd gotten COVID and had long COVID. Definitely done a letter where somebody's, a little hard to explain, but somebody's cultural differences meant they needed some additional care. There was a reason why they were getting care in a specific way. It's such a great way to sort of explain some intricacies that maybe the care tool doesn't capture, or some of the review might not capture. So it's a good way to sort of communicate with the agency and maybe come up with a solution without necessarily having to go to hearing. And then the next, and this will be you again, Hannah, but the next set of problems that we're going to talk about solutions for, or might be a solution, is the denial of benefits, maybe not enough benefits, or an involuntary discharge, and that's administrative hearings.
Yes. So I think we've mentioned request a hearing or a hearing a few times. And I know in other trainings, I like to explain, like, what does that actually mean? And again, this isn't just for long-term care, but these other state benefits as well. If you want to appeal a decision, so if you want to, formally say, I disagree, I'm disputing this, the method that you do that is you request a hearing. They're called administrative hearings. It's when a judge is going to look over the case to see if the department maybe did something wrong, or maybe there was something else that should have been considered, or maybe what happened is what aligns with the rules. So the hearing, it's essentially a request to ask somebody else, an independent party, to take a look at the case and decide if there was a mistake. And then you can request a hearing when your benefits have been denied, hours are reduced, terminated, if you receive an overpayment in a different type of case, if there's a change in care level. Generally, whenever there's like an adverse action that relates to your benefits, you have the right to request a hearing. I will say there are some programs where you do have to submit a written hearing request. Generally, folks can, there will be a number on the phone, or there'll be a place to send an address, to send a letter on that denial notice or the termination notice. It's going to tell you exactly how to request a hearing. So my advice is read the letter. And if you're not sure, if you're with a case manager and the client says, I think I got denied, I threw away the letter, which is really common because it can be really upsetting. You can always just get on the phone, help them request a verbal hearing, and then if they're instructed they need to do it in writing, you can help them. There is a form, but the clients don't have to actually use the form. If they do it in writing, they just have to write, I disagree, I want a hearing. There's not supposed to be like a magic word so that the client's supposed to say the words exactly right. Just any kind of disagreement is supposed to be understood by a department or customer service rep that they want a hearing. No, I think that was 90 days. So generally, you get 90 days to request a hearing from the date of the letter, that termination, the planned action notice. So that's 3 months. If you want, however, continued coverage, so if the letter is saying that your hours you're being terminated, your benefits are being reduced, or some coverage is ending, oftentimes you can request continued coverage, but you have to do that within 10 days of the date of that notice. So it's a little quicker. What I do with clients is, if I'm not sure if I'm still within that 10 days, but the client wants continued coverage, I ask for it. It's better to ask for it and learn that you're out of the deadline than to not ask for it and then miss the deadline so that you're not able to go back and get it. Okay, I think that was actually the next slide includes the contact information for the Office of Administrative Hearing. If you're having trouble getting through to anyone at DSHS, or you're not sure who to call, you can contact the hearings office directly and let them know that you want to request a hearing. You could submit a hearing request that way. This is their phone number, fax number, and their website. Okay, so this might look overwhelming or confusing, and I won't go through everything today, but I just wanted to kind of flag what the hearing process looks like, because it can sound really intimidating, and it can be intimidating. What I should have mentioned earlier on is you have the right to be represented by an attorney. Both my organization and Meredith's organization, we represent clients in a hearing. You also have the right to have a non-attorney, a social worker, a family member, a friend, your caregiver, somebody there to support you or can help speak on your behalf. So you don't have to go it alone. So generally, once you request a hearing, there's going to be a couple dates on the calendar. Pre-hearing conference, it's generally a check-in. The parties have a chance to talk about what exactly the issues are, and set any future dates. You have the opportunity to submit documents to the court. You can write a letter, or you as a case manager, you can write declarations. If there's maybe a medical issue that you think the court needs to know about, you can submit medical records as exhibits. And then when you actually have the hearing, they could be over the phone or in person, depending on what the client needs, if they want to be in person or if it's better for them to be over the phone. I included the WAC citation that just gives some more information. Well, actually, I shouldn't say I included it because I got this slide from Meredith, who I think one of her colleagues put it together, but the slide includes the citation if you want to learn a little bit more about what the process is. And I think this next slide is mine as well. If the client doesn't win at the hearing, if the judge upholds the department's decision, whatever that might be, that's not the end of the road. They have the chance to appeal to what's called the Healthcare Board of Appeals, which is a different judge who will review the decision, review the judge's decision, and see if maybe there was a mistake there. After that, you can actually appeal to Superior Court, which you're outside of the administrative world, but that's usually farther down the road. And this is just some more information. What I wanted to flag here is I mentioned there's that 90 days. And usually deadlines, when you think about appeal, hearing rights, 90 days is a good number to keep in mind. But if you don't win at the hearing and you want to appeal, deadline's actually 21 calendar days. So just flagging that it's a shorter appeal if you do want to keep fighting the case. Okay, I'll pause there and pass it back to Meredith.
Thanks, Hannah. Yeah, and I would say too, just a couple of comments. Like, I think the administrative appeal process is probably one of the most lawyery things we do, and yet it is open to everyone. I mean, the purpose of not just sending everybody to court and the administrative procedures that creating this venue for appeal was meant to make it accessible to anyone, not just lawyers. So as Hannah mentioned, you don't have to have a lawyer there at all. There can be no lawyers. It can be friends, family members, caseworkers. The long-term care ombuds, who I mentioned before, will sometimes come and represent people. Adult family home counsel sometimes represents adult family home, and they're not attorneys. So the idea is that it's meant to have a procedure and be formal and give people the chance to be heard, but it's also meant to not be scary and intimidating. And so oftentimes that happens by phone. The judge is formal, but also very helpful. So it's just having, and Hannah has too worked in different, courts and different venues. The administrative procedure and administrative hearings are really meant to create a space for people to be heard in a hopefully more comfortable, more accessible way. I want to talk about settlements and inheritances. So we get this a lot. Folks will call, and actually lawyers call me a lot about this too, about, hey, I'm about to get a big settlement from my client and they just told me they're on Medicaid. I'm like, oh my God, what are you gonna do? So it's a lovely problem, and it's also can be complicated. And just something to flag because it comes up and we deal with it a lot, and it's a kind of an interesting problem to solve. This is a slide I created. Obviously, you can see it talks about a lot of different kinds of benefits. We're focused on long-term care benefits, and as you can see, if they get a settlement or inheritance, it will put them over that $2,000 limit. We need to think about what to do with it, and the important questions to ask, obviously, what kind of public benefit, because some don't have an asset limit. Age can be a factor in the solutions that might be available. How much money they're going to get is a big deal, because if it's just a little bit of money, or a little bit, like it's still a lot of money to most of us, but if it's enough money that it's going to put them over 2,000, but it's not a ton, maybe it makes a lot of sense for them to come up with a plan to spend it. And then there are some other options in terms of special needs trusts that allow them to put the money away and use it over time on specific things and still continue to get their benefits. There are also, many of you probably have heard of ABLE accounts for folks who were disabled before the age of 26, they might be able to put the money into an ABLE account, and it's a great way for them to spend the money. So there are solutions. And again, sometimes it's a matter of going through some of the facts and figuring out what works best for the person. I mentioned before, if it's not a ton of money, but it's enough that it could kick them off their benefits, maybe it's time to think about things that they could spend it on. This sheet over here is actually on Washington Law Help, and we'll kind of show you where to find it. But just this is like the most fun advice I get to give people. Like when the advice is, well, you know what you should do is like spend the money. There's a time within which you should spend it, but like, here's some fun things you could spend the money on. Maybe you need a new car, to get to your medical appointments. Maybe you need, dental. I helped somebody recently who got to pay for their dentures because strangely, we don't include teeth in healthcare, whatever. Vacation and travel. So they're just some things to think through, just to flag this for y'all, but it's we've got a couple of publications about it. There is a way folks can receive the money and not also lose their benefits in receiving that money. Oh, I mentioned the gifts. This one is like, this is such a frustrating piece of benefits for especially long-term care benefits. I put the big like 5-year look back because this is where I get problems with people who've been denied. So the typical is somebody comes to me and says, well, I got denied. And it's because I, quit cleaning my house to my daughter because I want her to have it when I die. And I did that like 2 years ago. And it's if somebody gifts or sells something for less than fair market value, it's considered a gift and it's considered an improper transfer of your benefits. And I guess the best way to think about this is they don't want you giving away things in order to qualify for benefits. And that's often not at all what people are trying to do, but just to help you wrap your head around like why is it such a big deal. Really, the idea is you're meant to use your resources before you'll need the long-term care benefits. And if you give something away, it looks like you've given it away in order to reduce your assets and qualify for benefits prematurely. So just a thought, different solutions to the issue. And actually this kind of blends, but one solution is we have the daughter quit cleaning the house back to mom. So that's, and again, a sort of simple fix. And then sort of folded into this, let me say first, there are some people you can gift to where it won't screw up your benefits. So there are exemptions, a spouse, a registered domestic partner, your minor child, or a child with a disability of any age. And I've got these listed under estate recovery. So I'll talk about estate recovery real quickly because it's been mentioned, but it is true that in receiving specific kinds of long-term care benefits at a certain age, the department will have you sign a form that says that you agree that when you die, that they will recover from your estate. For our clients, and I just want to like tag something too, this can also happen if you leave your home and go to a nursing home. So it's not always just when you die. It could be you no longer need your home, you've gone to a nursing home, and now the state says, okay, well, we're going to go ahead and put a lien on your home. They won't execute the lien until you die, but we still get calls from family members who are frantic because they've just gotten a notice from the state saying, hey, we just put a lien on your home, or we're about to put a lien on your home, and it's scary. But there are lots of great solutions. And the idea of estate recovery is a good one. The idea is you no longer need your home after you die. And so, can the state recover some of the money that they spent on your care now that you no longer need your home? The problem is that there are some people who might still need to be in that home, including your spouse, including your domestic partner, your minor child, or a child with a disability, or there are certain other people who need that property to stay out of poverty, to stay out of homelessness. And so there, I've sort of listed some of these, the exemptions. There's no estate recovery if the folks listed under the exemptions are in the home and using the home. There's also the option of folks applying for what's called a hardship deferral to say, for instance, I'm the brother, I've been living in this home. If I can't continue to live in this home, I will be homeless because my income is so limited. And then and Jody, I think I saw your hand raised. Did you have something?
Just a time check.
Yes.
Okay.
Okay,
Thank
good.
you.
Oh, yeah. Okay. I'm gonna move on to the next one. Oh, Hannah, this is you, equal access plans.
Yes, so I'll just be brief. I wanted to flag this as a tip for advocates. I always like to, provide kind of tips and tricks. And one of these things is called an equal access plan. Again, it's not just long-term care, home and community services. It's you can have an equal access plan if you're receiving other other benefits. Sometimes I explain them or describe them as a disability accommodation plan, although it's not just related to disability. It could be based on if you have a language barrier or any literacy issues, you need large print. And the idea is that if you have an equal access plan, you get kind of extra help or an accommodation to be able to access or maintain your benefits. You can ask for it at any time. Sometimes I tell case managers, if you're working with a client who's constantly being denied, terminated, just things are happening, check to see if they have an equal access plan, because something you can ask for with an equal access plan is help filling out the form. So the client no longer gets terminated every time they don't fill out a form because they actually need help. Extra time, language access, translations, interpreters, large print if they're visually impaired. You can get a phone call every time you have an appointment if you miss an appointment. I have a client that when they go into the office, they get a quiet space. They're able to sit in an office when they meet with their caseworker. So just flagging this. If you're working with clients and you think they need an accommodation, they can ask for it. I think that was it for this slide. And
Yeah.
I think unless there's more you wanted to add, I was going to run.
No, but Hannah, I was going to say, I wanted to make sure we've got about 10 minutes left. I want to make sure to hear from Kayla. And so we're going to share our PowerPoint. This last bit was just about Washington Law Help.
Yes.
So if it works well for everyone, I'll just kind of skip over these slides and we can hear from Kayla and answer any questions.
Perfect.
Does that work? Okay.
Oh,
yeah,
yes,
Washington
that's
Law
great.
Help. Yay, here it is.
Just go to it, click on the links. Yeah, it's all there. Go to it. It's great.
Oh my goodness, thank you both. And yeah, Washington Law Help is something that Meredith and her colleague Ashley have shared with us before, and I feel like Solid Ground has offered it before. I mean, I feel like everywhere I go, people are like Washington Law Help. So we will get all these slides to you and all of that. And, I'm not seeing any questions in the chat at the moment, but if you're in the midst of typing, continue typing. If you're in the midst of forming that thought, raise your hand. I'm going to hand it over to Kayla she's got just a handful of slides, and yeah, we'll wrap it up here in the next 9 minutes. Take it away, Kayla.
Thank you. Yeah, I just have just a few. And I also want to plug Washington Law Help. Like, I love that website. I think it touches on literally all domains of life. But anyway, so let's see okay, this is the part where I get to be like, I don't know how to share my screen, but I can.
Do you want me to?
I can do this.
You can. I know you can. You
You
should have a button at the bottom that says share screen.
Yeah.
Sometimes it's highlighted green.
PowerPoint.
Yeah.
Share. Oh my God. Okay. Well, now it's telling me my computer isn't letting me. Can you do it?
I can. Yeah.
Oh, thank you so much.
All right.
The most recent one. Yeah. Okay, cool.
I think this is the most recent one. I had them both. Okay. So,
yeah. So this is just my little section. I don't think I've said maybe who I am. I'm Kayla Adams, client benefits specialist with REACH, and a big part of my role has been a partnership with the coalition as well as Solid Ground, and it's just been a really great opportunity to pool resources and learn things from each other. So I'm really grateful to be able to be a part of this. And you can go to the next slide. I already mentioned this, and I know that it's been touched on multiple times, but just in terms of like a therapeutic approach to preparing a client for a care assessment, or the process in general, is, I've already mentioned, being upfront and honest with your client about the process, being really transparent. It is definitely, I don't know, the best way for them to not be blindsided, right? And then helping them understand the purpose of the assessment, and that they're going to be asking some pretty invasive questions, very personal questions. And one thing that people have a hard time talking about, I've noticed in my experience, is that people don't want to talk about their limitations and their difficulties with certain things, because pride and various other reasons, and just, we live in a kind of society that really values independence. And so this is someone saying, I need help with these things, and it's just hard for folks. And so I developed, well, you know what, I stole it kind of and like made it my own, but it's a mini needs assessment. And you can switch to the next. It's just a little tool I made that will help you and your client. You can just go through it with your client. I've also just done it myself, like to have a sense of what my client's needs are, in my opinion. But I also make note that it is my opinion. And this is an unofficial document. You wouldn't give this to DSHS or anyone. This is like a tool to help document where your client's at, kind of. And I've used it myself. So it would help you and your client figure out how much assistance they need with ADLs, and then IADLs. So those are instrumental activities of daily living, which are different. So those are things like using the phone, managing money, things like that. Identifying limitations that a client has in terms of their functioning, whether they can toilet on their own, whether they can shower on their own, things like that. Also, HCS is going to be interested in the sources of support a person has, whether they're formal, like a professional, like a case manager or someone, or informal, like does this person have friends that help them, that they can rely on, and they're going to take all of this into account. And then what your client actually wants and needs, because again, these are entirely voluntary. So I also like to note any discrepancies between what I believe the client needs and what they believe they need. I'll drop this file in the chat too. And maybe they can include it on the coalition website, maybe, I don't know, because I think we only have like a few. Anyway, yeah, so I don't know. It's a helpful tool just to see where someone's at. And you can go to the next slide. A question that I have asked multiple times, and I've been asked multiple times, is what do I do if my client declines services? And I already touched on this a bit in terms of the money, substance use, and cigarette use. There's a lot of facilities that will not allow cigarettes even like smoked that closely to the facility. Like there's a lot of facilities that are like that. There is one in Renton that I really like, and of course I can't remember the name, but they have like a courtyard where people can smoke, but that's like as good as I've seen it. Obviously they don't want people using substances just anywhere and everywhere in the facility. So I say obviously because it's, there's the stigma with that, and then there's, I don't know, they could probably lose some licensure or something. But big thing is people who are using substances regularly might not even want to enter into these facilities, knowing that that part of their life is essentially over, or they're going to be asked for it to be over. And if they get caught, they might get kicked out. Fear is at the top of the list too, though. Fear of being in this system and never being able to come out, something that I don't think we touched on is that you can enter a facility, an adult family home, an assisted living facility, and decide no thank you and leave it. I mean, it isn't all that easy to just go back to where you were maybe, but there's no one holding you there. It isn't like the old days in the hospitals, and it's nothing like that. And so if a client declines services for any reason at all, I just want case managers to know you have to accept that decision to a degree. Like you must respect it, because you cannot force them to do anything. But there are a couple of little tips and tricks I have that might help you if you're in this situation. If you want to go to the next slide. First of all, I would do some case consultation with either your supervisor. Maybe you have a team of folks, maybe like their whole care team, if they have people from other agencies as well. Have a care conference and talk about it. I'm all about care conferences, and I'm all about care coordination. So someone might have an idea that you haven't thought of. And yeah, there's just a lot that can be done there. Depending on the severity of the situation. So no one wants to take away a client's rights. I understand that. And in fact, putting someone getting someone through this process and them choosing to live in a facility like an adult family home is voluntary, and it is very respectful of their rights. But if you have a client who literally is if their condition is potentially life-threatening and it meets the criteria for like a DCR referral, a referral to the designated crisis responders, I have done this, and it has actually gone well, in that the client was so ill and so out of touch with reality. He was not taking care of his diabetes. I ended up having to detain him. And he went from the hospital, where after his diabetes cleared up, he was put on an antipsychotic, and then he moved into an adult family home, and he's been there ever since. And it wasn't easy, don't get me wrong, but like, it's one thing you can do if it is that dire. I have no more time. Shit. Can I just go through the last few and people can stay or not? Okay. Another thing I really, really recommend is if you have a client who's like, I don't need this help, then you can, I would just start working with them around motivational, like using motivational interviewing techniques. So helping them explore why there's a discrepancy between what you see and what they see. And to be clear, like, this isn't just being like, you're wrong. I mean, there are techniques, and I actually will also drop a file of like just a very basic file about motivational interviewing. And then I also want to plug King County Behavioral Health and Recovery Division. They put on trainings often. I mean, I think it's once a week, but motivational interviewing's in there often, and like I said, care coordination's in there often, and one on ITA. So if you are like, what the hell are all you people talking about? I mean, there are opportunities to learn how to do these techniques as well. The big thing is, just a quick example, I had a client who she was given the option of of moving into an adult family home. She was very ill, and she also used substances daily, and was like, no, I can't use substances. They're going to take my money. I'm over it. I'm not doing this. So what I saw was a huge decline in her entire well-being. And so what I would do, I mean, we would talk, and she would tell me about the difficulties she's having, and I would say, I know, and unfortunately, you're in a position right now where you need more help than you're getting, but the help that you could be getting, you're refusing. And so it's a hard conversation to have, and it does require some nuance. But like, at one point, this is when things changed, is she was like, just, I mean, it's sad and it's graphic, but like, she was just on the floor in her apartment, like, couldn't get up. She could not transfer on her own. And she was like, I can't do this anymore. And so I was like, well, here, it's a really tough time to have this conversation, but this is why I wanted you to go into an adult family home. And she did agree to it. It took another, I think, 2 or 3 hospital trips, but it's like planting the seed and making sure that they are also observing where they need help. It all sounds so simple, maybe, like as I vocalize it, but it is hard and it does take a while. But that is a huge thing that I ran into so many times with my own clients, and I got lots of questions about in my current position. What do I do if my client needs this care and is refusing it, essentially? And I think that's it, but if you want to do oh yeah, like I said, keep an eye out for trainings about motivational interviewing, and you can even use that example, because they love examples in MI, to do a practice on. And again, I can add that to the chat if there's anyone else. Yeah. And then feel free to reach out to me, because I love these types of questions. I have a lot of different ideas. They're not all good, but they're like something that might lead you to think of something else. So, woo, I think that's it.
Thank you, Kayla. That's great. And this is what I'm looking for.